Good. Well, I think we should probably start. Good evening to all. I'm Ronan O'Connell. I'm president of RCSI, and you're very welcome to our Wednesday evening, or if you're in the Gulf region, Wednesday late evening or even nighttime webinar. And we're very grateful to Professor Martin Corbally, who's Professor and Head of Department of Surgery in RCSI Bahrain, who has put together an interesting series of talks this evening from our esteemed faculty. So we welcome Professor Manaf Al-Khattani, who's a professor in the lead in microbiology at RCSI Bahrain. He is a specialist in adult infectious diseases and clinical microbiologist and consultant and head of infection control at the Royal Medical Services of the Bahrain Defence Force BDF Hospital. Dr. Hurira Kazim, who's medical director and consultant breast surgeon at the Well Woman Clinic and professor at MBRU University in Dubai, UAE. And Dr. Almira Balaras, who's Director of Clinical Training Administration at the King Fahd Specialist Hospital in Saudi Arabia. And the question we have for you is, how are you managing to recover from COVID-19 in Bahrain, Dubai, and Saudi? Because we're just beginning to emerge. And when we had presentations from Bahrain late last year, I think we had much to learn from you, your experience. Because the Gulf states were affected by COVID earlier than we were, but you seem to have responded more rapidly and to have managed to keep scheduled services going when we were finding it difficult. So we have much to learn from you. The other thing that struck me very much was that during our charter meeting recently, when, as you know, we went online, it was a virtual meeting and we had so many delegates from all around the world, but we had large numbers of delegates from the Gulf region, particularly Saudi, Bahrain and UAE. And so it's to that constituency also that we are looking this evening. So if you have questions, please use the chat function. And Professor Corbally will put them to our distinguished presenters at the end of the meeting. Please keep your microphones muted, otherwise we tend to get an echo and feedback. So Martin, I'd be grateful if you take over, and thank you very much for organizing this interesting evening.
Thank you very much, Ronan. It's a great pleasure to be here and indeed to welcome our three distinguished speakers this evening. Ronan has already introduced Professor Manaf, and he needs very little introduction, I'm quite sure. I'd like to congratulate him on his recent promotion to full professorship at RCSI. As many of you know, Manaf has been the lead in adult infectious diseases here in Bahrain for some time and has played a lead role, in fact, in the country's response to this pandemic. I'm quite sure that everyone agrees that we've had so much to learn in a rather short period of time. And I think it's to people like yourselves, or distinguished speakers, that we look to for advice and have looked to for guidance as how we progress through this somewhat uncharted water. So without saying any more, I'll ask Professor Manaf Al-Khattani to proceed as the first speaker.
All right. Thank you very much, Professor Martin. It's a great pleasure to be here tonight with you. It's a very warm welcome from Bahrain. The weather around 21 degrees. We had a beautiful weather a few days back. I think it's the start that we're going to have the first wave of heat beginning of April. But I think summer is coming too soon here in Bahrain. I have a few slides to share with you, if you don't mind. I'm just going to pull my slide first. As Professor Martin was saying, can you just see my slide?
Yes, yes, we have it. Yeah.
Perfect. All right, so it has been a tremendous learning curve for me to begin with. It has been almost over a year now trying to combat COVID-19 here in the Kingdom of Bahrain. Just to give you some background, in Bahrain, we are around 1.4 millions, and my presentation for tonight gonna really be divided into three parts. First, we're gonna talk about the Bahrain approach in combating COVID-19. Then I'm gonna take you through the COVID-19 vaccination rollout plan in the Kingdom of Bahrain. And finally, we have done a tremendous collaborative research between RCSI Bahrain and the National Task Force team here in the Kingdom. So it has been a very productive year for me individually and for Bahrain in general. So way back in January 2020, this is the first time we have started to prepare for the predicted pandemic. Even though the WHO took some time to announce the first pandemic late in March, but we all knew from the cases that has been arise in China that this is something that we're going to deal with. And there's no secrecy since 2002 until now, we've been bombarded with so many emerging infections, H1N1, avian influenza, and now Ebola as well, and now with this amazing coronavirus. So the first thing we have done way back in January, we have set the plan, what would happen if we start having the first case here in Bahrain. Bahrain is a small island. Bahrain has a diversity of mix of population, 44% representing, 45% represent national Bahraini citizens, and the rest would be from different the globe, primarily from Asia, but we do have a quite percentage, around 20% are from the Western European. So you can imagine the diversity of the culture and the diversity of the behavior. And one thing we have learned from this COVID-19 is that the behavior of the virus is affected by the behavior of the individual. So we really needed to set the rule and the behavior of individuals so that we can all together fight this emerging virus. So the first thing we have done, that His Majesty the King Hamad, he actually ordered that testing and the treatment gonna be free for all citizen and resident in Bahrain. And I think that's the key thing that we have provided, not only for Bahrain, but even for the residents. All the testing and all the treatment comes along free for Bahraini and residents. However, we have also established a national task force team comprising from 26 members from a higher authority to diversity of specialty, mainly infectious disease, microbiology, but also from public health. Those are dealing day to day in a meeting in handling the situation in the kingdom. We have learned from MERS-CoV in Saudi that the majority of the cases and the outbreak has been arising from the hospital. So hospital has been always the issue for us. So we decided back in January, before even the first case, we decided to have a fully dedicated unit for COVID-19. So we started with 4 units, a capacity of 300, up to 26 facility that give you a total of 9,000 bed dedicated for COVID-19, including 325 bed fully dedicated for an ICU, which we're going to talk about it maybe the next few slides. We also felt that random testing would be the initial step that we should do to look for community transmission. However, as you know, at the beginning of the pandemic, it has been basically an international entry of the COVID-19. So we have set the border clear and set the strategy and the protocol to detect any case that comes abroad. One key thing as well, the early response, I think that's the big lesson that we have learned, is that we have created a central room, we call it the war room. This is to coordinate all the governmental actions in combating COVID-19. You're talking from the Ministry of Health, Ministry of Interior, talking about public health itself and central lab and the media as well. So those all are under the control of the central room. It's a compromise of 27 members taking care of COVID-19 in Bahrain, working 24/7 a day. As I said, we have dedicated specialized facilities for COVID-19. We didn't want to involve COVID-19 in the major governmental hospital. For the risk, we were afraid of hospital transmission. At the same time, we didn't want that the non-COVID care should be affected during the COVID-19. So that's why we have set the bar, and we have, as I said, established initially 300 beds, but then we expanded to 9,000, and now we downgrade to 5,000 beds, depending on the need and the capacity. 90% back in February, the majority of the cases were coming from the international. So as I said, we have set the rule and we have set the testing. We established the first PCR lab testing in the airport to test all the arrivals. And at that time, all testing has been free of charge for the passenger arrival. We have depended on the 3T strategy. And I think that was the key success: testing, tracing, and treating. Would you believe that for a size of Bahrain, 1.4 million, we have done over 3.5 million tests? You're talking about roughly around 15,000 tests per day. Bahrain becoming one of the top 3 countries worldwide per capita for testing. So testing has been really repulsed, and we started with 200 tests per day to up to 15,000 tests now per day. We increased the lab capacity from only 2 labs in the Kingdom of Bahrain to a 10 lab, molecular lab, fully dedicated by the manpower. And that's one of the challenges, to find the people to run the labs. So we have to learn from the scratch. So it's a self-learning, train the trainer. So we start to train most of the microbiology technicians in the Kingdom of Bahrain, and then we've hired even some volunteers or some retired microbiologists, and we train them in the microbiology. So we really depend here on testing. And as I said, until this date, we're doing 15,000 of tests. Contact tracing as well has been the landmark in capturing those infectious and daily reporting of them. We have done so far 300,000 of contact tests. Again, just to remind you, for a population of a size of 1.5 million. And as I said, we have really dedicated 26 facility purely for COVID-19, fully equipped, and over 326 ICU beds with 500 ventilators. And I think this all comes from His Royal Highness Prince Salman, the Crown Prince. We actually have prepared to have 500 ventilators even before the start of the pandemic. This is the visionary of the leadership. When you think if the pandemic gonna come, you're gonna really need to set up your critical ICU care, and this is where we have really invested. And when we have utilized only 300 out of them, we have donated the remaining of the ventilators to the neighborhood countries, mainly where Jordan and Yemen as well. So one of the early and innovative response were several points that I would like to highlight. We have done the daily task force meeting beginning of February the 10th. That was didactic, chaired by Sheikh Mohammed bin Abdullah. He's the chairman of Supreme Council of Bahrain. We have around 27 members. We meet daily. It was face-to-face back then in February of last year, and now we do a virtual meeting. I think you are aware that Bahrain became the first Arab country to join the WHO Solidarity Trial, and that was a great initiative of Bahrain to involve even in research in providing some answers to the humanity. We have, as I said, increased the PCR capacity from a few hundred to 15,000 tests per day. We also have initiated working from home, 70% work from home, knowing that in certain situations, people might bring the risk of the virus from the community to the household. Masking there has been a big debate even back in April 2020. We did not believe of it at the beginning. However, we have seen the tremendous success with just non-pharmacological intervention like masking. So masking has been mandatory in the public since April of last year. We have banned public gathering, so we started with 5 and then we expanded to 30 depending on the newly cases, but that has been the ongoing until this date. We have never closed our border. We have never closed our airport. Even the causeway has been the closure of the causeway has been taken by our neighbored Saudi Arabia. But until this day, we have welcoming up to 140,000 passengers coming across. This is a very challenging area. I'm a member with the aviation in the WHO. There's really nothing in the literature that support closure of the border would be of any value. We have seen it in the Ebola. We have seen the catastrophe, and when you close the border to the humanitarian aid and to the transfer of the medical equipment. So even keep that in mind. We've kept the border open, but it has been monitored. And when I say by monitored, we apply rigorous testing upon arrival. One unique innovated we have also done earlier on back in May, we have done the mobile testing. This is called the drive-in testing, and this is separate than the drive-through as well. So we go to the villages, we go to the labor camp, and we offer testing for free. Not to hide, Bahrain, one of the highest country per capita having the labor camp, and most of the people that from the labor camp comes from poor socioeconomic. And so we had to take the lead and we had to approach them and go to their place for testing without the fear or penalty from being positive or even departure. We have not departed any expat, even if they test positive. We have also launched the first automated application called the Be Aware application. This is where you can get your result online. The turnaround time to get your result in Bahrain is not more than 12 hours. We are aiming for 6 to 8 hours, and the maximum is actually within 12 to 24 hours. We use also the contact tracing through the Be Aware, and even our vaccination program also has been launched through the Be Aware. We have done tremendous vaccination campaign, which I'm going to talk about it in the next few slides, but Bahrain has taken the initiative in enrolling with the phase 3 clinical trial in cooperation with Sinopharm and G42, Sinopharm from China and G42 from the United Arab Emirates. We have enrolled over 7,000 volunteers back in July in 3 weeks. And I think that's also a record. And that gives you the transparency and the trust of the public on the governmental action. We have used one of the unique testing methodology back in August of last year. We call the antigen test. There has been a big debate about the antigen test. Most scientists, and I was one of them, we had a big debate about the utility of antigen test. One thing I have learned from testing modality is sometimes we really need to think outside the box. And rather than just thinking of the sensitivity and the specificity, it's also going to be what do you need from the test? Even though the sensitivity of the antigen test in comparison to the PCR, which I'm against in comparing to different methodology, PCR is completely different than the antigen test. But even with having poor sensitivity of antigen test, the main idea of applying the antigen test was actually capturing the infectiousness rather than the non-infectiousness. And we have done thousands of cases, which I'm going to share with you in the next few slides, about the utility of antigen tests and how antigen tests helped us in capturing those who are early infectious. So we talked about some measures. So we have reduced some flight, but we have never closed the border. We have closed. We are one of the earliest country in the region that we have closed the schools. Fearing or keeping in mind, children are one of the bigger risks in carrying the infectious viruses, and they could easily transmit it to their family. So we have shut down the schools. We have started the online education or the virtual learning. Bahrain considered one of the successful lead countries in the region in applying the virtual learning. The learning curve has not been affected here in the Kingdom of Bahrain. We established the international reputation program. So we had more than 4,000 people back in February of last year will be abroad. So we established a program how to bring them safely to to Bahrain without affecting the rest of the public. Recent measures that we have done back in July as well, we have initiated the home isolation. Well, one of the things that that you have to know, you have to know about Bahrain, we really wanted to set and educate the community about home isolation. It took us 3 months to prepare the community to prepare for home isolation. So at the beginning of the pandemic, we used to admit every single person, whether you're symptomatic or asymptomatic, but that was for a reason. One reason we wanted to learn about the clinical curve of COVID-19. And we have learned from it that even if you're asymptomatic, that by day 5 and day 10, you might deteriorate, especially in those who are high risk, and those would be the elderly people. So this is actually have set the bar, have set the rule, and they set the policy. And it took us 3 months, as I said, to prepare for the community to accept that if you are one of those who are the lowest risk, that you should be self-isolate at home. And that's what we did exactly. So we have set a program fully supported by the primary health care. So they have a phone call every day to look after those who are in home isolation, to make sure that they don't have one of the alarming signs like shortness of breath. So we have provided them even with a pulse oximetry for free. And for any person who has a saturation less than 93, they have to call the 444, and the 444 actually is one of our central communication center dedicated only for COVID-19. So we had to separate 999, which is for the medical emergency, and 444 was purely dedicated for any matter related to COVID-19. Contact tracing. This is something that we really invested our money and time. So as I said, we have done until this date more than 300,000 of tests. Almost 55,000 came back positive, so you're talking about 16.5%. But one thing we have learned from the contact tracing, as I said, is that the behavior of the individual reflected on the behavior of the virus. So we had 3 spikes in the Kingdom of Bahrain. The first spike was early May. That was from the labor camp. Again, labor camp, those population has been really crowded in a very poor ventilated accommodation, and it's of no brainer. Those would be the higher risk. So we really, and that's the reason we have targeted those camp initially, and we have provided the free services for testing and even for isolating. We provided 4,000 bed facility in Sitra. It's a small island, fully dedicated just for those who are unable to self-isolate themselves at home, or they don't have a place to self-isolate. The second spike that we have learned that came in September, it came during one of the religious events that we have here in Bahrain. The majority of the cases came from the household. Just to set, we have Ashura in September. Ashura, it's a very dedicated religious day for the Shia population, where they have almost a full month activities engaging with the spiritual and some religious activities. So we had the major outbreak during then. The majority were from the female and the young population, talking about children. And the third spike is actually came after Christmas, New Year, and after enrollment of the vaccination, and that was in December, January, with the emerging of the new variant, which we're going to talk about it also in the next few slides. So what's the unique about the vaccination? People had the false secure that if I'm vaccinated, I have the freedom of doing anything. So this is where people get gathering without masking. We had social partying back in December and January, and we have the highest spike in January and February, and now we are really recovering. This data actually helped us, and this contact tracing has helped us in controlling our activities. Rather than doing the complete lockdown and shutdown of the services, we really targeted those hot zones activities, and we actually monitor those activity or services, and we had to close them down, but we have never locked down the country as such. This is just to give you the trend of the cases since the beginning of February of last year until now. So we reached almost 8% of population get infected with COVID-19. So around 127,000 out of 1.5. You do the math, you get 8%. The recovery rate is almost up to 94-95%, and again, that's an excellent percentage recovery rate that we have. Bahrain considered as the fourth country when it comes for testing per 1,000 people. The vaccine doses, we have reached almost 300,000 vaccination. And if you go per 100 people, we are ranked as the fourth. Israel, UAE, and UK are the leading countries in terms of vaccine rollout. In terms of effective treatment, as I said, 94% to 95% our recovery rate. We have 0.36%. That's our mortality as an overall. The majority of the cases are asymptomatic, that's 66%. However, the trend has changed since the emerging of the new variant, and up to 98% of the daily new cases here in Bahrain are actually for the new variant, and particularly it's the B117. Again, I think Bahrain, we're lucky that we have introduced the vaccine earlier on. Otherwise, I think with the new variant, we're going to have catastrophic result. This is, I think, the main slide that I want to share with you. So we have introduced 5 different platforms of vaccination. So we have the Sinopharm, this is the inactivated vaccine. We have the messenger mRNA, that's Pfizer. We had the vector-based, and that is AstraZeneca and Sputnik. And now we have introduced Johnson & Johnson as well. So we have our targeted population from the 1.5 million are actually 1.1 million. Those are people above the age of 50. So we really make it very simple. If you are above age of 50, so you are the top priority to get the vaccinated. Until this date, until this time, we have vaccinated up to 27% of our targeted population. But more importantly, we have covered 42% of those who are above 50 years old. And we have covered 81% of those who are registered from those who are 50 years and above. If you go for those who are 6 years and above, so we have covered up to 46%, and that is 84% of those who have been registered. And the same thing goes for those who are 70%. From the healthcare worker, up to 61% of the overall healthcare worker in Bahrain, there are roughly around 16,000, up to 62% they get the vaccinated, including pregnancy as well. What was the efficacy or effectiveness, I should say, of the vaccine with the new variant? And I think this is one thing I would like to share with you. This is unpublished data and peer-reviewed yet. From the 300,000 who get the vaccinated, we've got 607 infected cases. And that gives you 0.3% of the overall cases. Now, if I look at only those who completed the 14 days, 2 doses of the vaccine, we have 456. And for those who are 456, we looked actually at their transmission of infection to the other people. We have a reduction rate of 42.4% for those who are vaccinated in transmitting the virus in comparison with the same period, with the same number of contact for those who are non-vaccinated. Again, it's not 100%, but 42%, I think it's a really good. Out of those, 18.2%, they are carrying the new variant, the B117, the UK variant. This is very encouraging result, I think, for us. It just tells you that you have done the efficacy during the trial. Now, the real world effectiveness of the vaccination has been shown, even against the new variant. This is the different platforms that we have. We don't have Moderna yet. We don't have Novavax yet, but one of the strategy here in the Kingdom of Bahrain, we actually have been approaching the manufacturer since August of last year, just looking for any potential vaccine, knowing that there are going to be some shortage supplies. So we had to secure good amount of vaccine, and that was one of the reasons we have enrolled with Sinopharm to secure almost 500,000 of doses for the Bahrain and the citizen of Bahrain. I think that this is just going to be the last few slides. The use of rapid antigen tests. We have applied antigen tests in school, in sport event, in hospital, healthcare worker, and even in the community. We have seen tremendous effect of antigen tests. Antigen tests actually capture those who are highly infectious. It's self-collected. We have done them in the school. We have a great success. When we reopened the school back in October, November, before we had a spike of the cases, the parents and the children felt much secure in going to school. Just to remind you, the school has been an optional. If you decide to take your kids, you can, or otherwise you can do the virtual learning. We have done also gene sequencing in Bahrain. We started back in April. We started in collaboration first with the Harvard University, and now we have the fully dedicated lab in doing local genome sequencing, and we have done over 4,000 genome sequencing since October of last year. And lastly, I know I'm over the time, research efforts. So we have done 33 research with RCSI. I'm happy to say 12 has been published. They are peer reviewed. We contributed with 2 manuscripts with the WHO. We have now 8 under review, and we have 8 in progress. I know I have short of time, but there's so much to say about the research, but I think I have taken much of my time. It's over now. Thanks, Martin.
Thank you very much, Professor Manaf. I'm really sorry to try to cut across you there. I feel that perhaps we need a lot more time to discuss the achievements across the Gulf, and I apologize that we're kind of pressed for time. What I'll do is I'll hold on to questions until the end of the webinar, and I'll ask people perhaps to enter their text in the Q&A section that you'll see on your screen. It now gives me great pleasure to present Dr. Houria Kazim, who is a graduate of RCSI Dublin and an RCSI Fellow. She is Medical Director and Specialist Breast Surgeon at the Well Women Clinic in the Arab Emirates. And she was, in fact, the first female surgeon from the UAE. So great congratulations on many scores. So I'm not going to spend too much more time, as time is now precious, and I'll turn the floor over to yourself, Dr. Kazim.
Thank you. Thanks a lot. And so I guess I'm going to give a slightly different perspective. I am a surgeon in Dubai, and I work 100% in the private sector. Obviously, you know, whatever happens in the country is affecting us as well, but slightly differently when you work for yourself. Can people see my slides? Yes. Just want to make sure.
There's something loading there, I think.
I was having problems earlier. That's why I'm asking.
Yes, we can see your slides. Thank you.
We can see your slides, yes.
So I think
Yeah,
I'm just
okay.
my first few slides are very similar to what Dr. Manaf has about basically the timeline of what happened in Dubai, and it's very similar. And I think that's the nice thing about COVID is, as much as, you know, I think political bodies make us think of countries as being separate entities, but actually it's amazing how in the space of a few weeks we went from, you know, a virus being identified to having a global pandemic. So same, as you know, the virus was identified in January. We had a family, so January 12th, that novel coronavirus. January 16th, a family of 4 arrived from Wuhan in the UAE. By the 23rd, the granny of that family was taken to hospital, and the 29th of January last year, we had confirmed our first case. March 8th, our schools closed. So that was before the global pandemic was actually announced. And then all the usual things of, you know, trying to get people home, and we started a sterilization campaign and curfews at night, and fish markets were closed. And the good news is we got Skype for businesses and Zoom and Teams, because all these things were actually blocked in the UAE. Flights stopped, metro stopped, and in April 4th, we had a countrywide mask mandate. And the interesting thing is, last year, at the end of last year, October last year, we were supposed to have Expo 2020. But in some ways, I think Expo might have saved us, because we were having Expo, I suspect there were already things that were put in place for an eventuality like COVID. Obviously, nobody knew what COVID was when these things were put together, but they would have been expecting one of the other coronaviruses, or Ebola or whatever. So it was quite interesting how swift things were put into place, how the schools were closed even before the pandemic, the global pandemic was announced. So for me, what did I find? There was a lot of talks about PPE. I have to say, we didn't have a shortage. There was people were being very selective about giving it in the operating room. So whereas normally you would have boxes of face masks, for example, in the scrub room, you had to actually go to the storeroom and somebody would hand you one. But we were not wearing black plastic garbage bags or anything like that. We had when we had our shutdown, we had a 3-week shutdown at one point, and we had an app that we had to use to get clearance. So I could work if I had an emergency, but I had to get clearance first before I could leave the house. Field hospitals opened, and access to treatment in the government hospitals and field hospitals were free. Local medical licensing bodies amended their requirements, and so we had reciprocal agreements between the different licensing bodies. So we have a Ministry of Health, which is federal. Dubai has its own health authority, and then we have a free zone, Dubai Healthcare City, and now we could work basically within any of these areas. It was interesting that to staff the field hospitals, a lot of the doctors in my clinic were volunteering, and also for the nurses, the government had asked the private sector to give up 1/3 of their nurses. They would be paid for this, for the COVID situation. In my own practice, obviously, you know, with the shutdown, of course, there were no cases or just emergencies. And then as we started up, we were asked to cut the number of patients that we saw. We had to stagger appointments so that, you know, you didn't have more people in the waiting room than necessary. Sometimes patients would wait in the cars, would telephone us that they were downstairs, and we'd tell them to wait until it was time for their appointment. We had to have special seating arrangements, and only urgent cases for surgery. They were discharged the same day. One of the best things I did was the year before, I had gone to a conference in Dallas, and they were running in tandem with this as a workshop on pectoral blocks, and I did the workshop. And so it was great because then I could do mastectomies under a regional block, and also for pain control. So we could get patients home, because patients in this part of the world actually like to stay in hospital. It becomes a little bit of a festive time post-op, where their families bring food and coffee and tea, and the carpet is laid out. And so trying to get patients in and out without all the festivities was interesting. Doctors volunteered again. The third of the nurses were gone, and something that we don't talk about a lot is that, you know, from a revenue point of view, my clinic dropped 75% if you look at the monthly revenue in February 2020 versus April 2020. And then what's the impact on women? Because of course breast cancer is not going anywhere, COVID or no COVID. Women were not coming for screening. So these are, you know, asymptomatic women. Women who were symptomatic were definitely delaying in their diagnosis. We've had 40% less cancer diagnoses last year than we had the year before. And obviously there's no decrease in the incidence of breast cancer. So that it's specifically related to people not wanting to come to hospital or clinic during the pandemic. Lots of PCR tests for our patients during chemo. For patients on the 3-week cycle, we would do it at the start of each cycle. And then if they were on a weekly chemo regimen, then we would do it every 2 weeks. We changed our surgical plan. If we thought a patient may have to have chemo, we would delay the surgery and start with chemo, or sometimes put them on hormone therapy for at least 3 months, hoping that things, I mean, we had no idea that we were going to be a year later in the situation we're in now. So we were just trying to delay to see what was going to happen next. And a lot, sometimes we did part surgery. So if normally a patient would need a mastectomy and reconstruction, we do the mastectomy with no reconstruction and then have to bring them back to have their reconstruction. So it means patients actually having to have additional surgery. We've had instances, we test our patients for PCR before, oops, I don't know what happened there. We test our patients, our patients do a PCR test before surgery. And of course, we've had instances of positive, I don't know what happened there. Okay. We have patients who have a positive PCR, and then we have to put them on hold. The interesting thing is we didn't know how long to put them on hold for, because some people could test positive for 3 months. And obviously, again, you know, the patients were not allowed to have any visitors with them. So they would be dropped off and walk into hospital to have cancer surgery on their own. I have a feeling you're not seeing my slides anymore.
I haven't been able to see
not
it.
anymore.
It's carry on,
Yeah.
Dr. Gissam. I think everyone's listening attentively. Yeah.
Okay, sorry, because it's just sort of disappeared. I'll try,
Yeah.
I'll keep talking, but I'll try to get it going. So the reality for patients is that they are anxious. You know, breast cancer is a very emotive subject. And let's not forget the mortality of cancer is actually higher than COVID. And so these patients have anxiety about, you know, not one, but 2 potentially lethal conditions. And on top of everything else, you know, women have during this time extra activities at home. Many of them were working from home. Kids were being homeschooled. So they're trying to deal with all of that and have their cancer and be afraid of COVID as well. So back to Dubai. So later on, we started having, so just like Bahrain, we did a lot of testing, tracing, isolating. We had drive-through PCR tests, which was free for locals, free for residents over 60, those with chronic illnesses. We have companies that'll come home and do tests for you. We've done about 33 million PCR tests as of now. Our population is 9.8 million. And of course, there's telemedicine. I guess it's a blessing to patients to be able to have adequate and timely care. Insurance companies responded by covering these telehealth consults. And I personally didn't care for it much. I just, I try to imagine giving bad news by Zoom. It's just so impersonal, but I guess it's better than nothing. In terms of charging, psychologists charged at par for these telehealth consults with what they would charge with an in-person visit. As clinicians, we tend to bill less because we feel if we don't examine the patient, it's unfair somehow. Obviously, the economy, like everywhere else in the world, economy of Dubai was brought to its knees in the early part, particularly related to tourism and air travel. But by the summer, with all the testing and tracing and isolating and treating, we started doing okay. We had that nice little fall, I think most countries did. And then when schools opened, we had another rise. And then, for reasons other than public health, I imagine, Dubai decided to fling its doors open with this travel corridor between the UK, which allowed travelers to board flights to Dubai without presenting a negative PCR, and they waived the 14-day self-quarantine that we'd had in place at that time. And if I show you, I mean, it wasn't like the UK was at an all-time low. They were actually at the peak of their second wave on the 14th of November. But hotels in Dubai were full, and of course, our COVID numbers tripled. And if I take you back, you can see, like everybody else after Christmas, that nice steep curve. So we're paying the price. Suddenly we had another flurry of public health rules and regulations. Businesses were closed down by the authorities for not following their strict social distancing rules, etc. Very strict rules on social gatherings. So, for example, only 10 people at home, and they must all be first-degree relatives. Sadly for us, on January 21st this year, all non-urgent surgeries were suspended, and that is still in place today. On the 29th of January, so much for the corridor, the UK banned all direct flights from the UAE. And of course, the death toll that this pandemic is wreaking on the healthcare workers as well as everybody else. And I don't think we really have stopped to think about the mental health of our frontliners. These are our numbers right now. This was yesterday. And so lots of vaccines, lots of tests. We are now about, we've finally dropped below 3,000 cases a day, and our prevalence is about nearly 18,000. So we wanted to talk about recovery. I'm not sure we're actually there yet. I know this pandemic has turned our lives upside down, but I don't think we're actually through it. If you look at the curves for Ireland and the UK, the shutdown certainly has helped. That nice spike that everybody got after Christmas has come right down. The UAE is taking a slightly different policy. They are not shutting down anymore. They are vaccinating, and they're still continuing with extensive testing. So December, we rolled out, Dubai rolled out the Pfizer and BioNTech vaccines, and Abu Dhabi rolled out the China's Sinopharm. Initially, it was for all Emiratis, legal residents over 60, those with specific chronic illnesses, frontline workers, but very quickly has opened up to any legal resident over 15. The Oxford AstraZeneca has arrived. Sputnik has been approved for emergency use, and we and the government will send teams of people to homes to give vaccines for the elderly. So, for example, my dad is 93 and my mom's 82, and they send a team home to vaccinate their entire household. And so this is the COVID vaccination doses administered in the UAE per 100 people, and we are now, as of yesterday, at 63.95%. So is it the silver bullet that I think that the UAE thinks it is? I'm not so sure. Yes, our vaccination rates are up. I think getting to a rate of 60, 70% is not difficult. If you have the vaccines, I think it's difficult getting higher than that, especially in the people who really need it. As Dr. Manaf was talking about, the people in the labor camps, etc. The efficacy, we don't get a lot of information locally on the efficacy of the various ones, in particular the Sinopharm. There is some news recently that that people are not mounting an antibody response, and Sinopharm has now started giving a third dose to those who don't have antibodies. And then myself personally, interesting that when people first started getting vaccinated, I was seeing patients suddenly turning up with axillary lymphadenopathy, and it took a little while for the penny to drop. We kept going, oh my God, what's happened? Where's the cancer? And actually it had nothing to do with cancer. It was, it's well documented now that it's from the vaccine. So we're playing catch up now with, having done really well. We did a great job from the beginning. We're lucky, we're fortunate here that we can afford the amount of testing, we can afford vaccines. But in my own practice now, what we're trying to do is catch up with screening, because we have a huge backlog, and catch up with all the patients that were half their surgery was done and they now need the other half. The problem is we are now not allowed to do those operations, because most of those second operations were reconstructive surgery, and that is not considered an urgent operation. So there are some good things that I've seen. I mean, I look around and I realize that, we take a lot of things for granted in our lives. And I think one of the things that I realize, as much as I consider myself as an independent person, that I've lived on my own and I've moved and lived in numerous cities during training without knowing anyone there. But this pandemic has made me realize how much I miss social interaction and simple things like hugging my parents or even my patients. I miss that. I realized that we're more flexible than we think. I think we've really changed and adapted rapidly to the situation, and it really is a testament to how resilient we are as humans and as doctors. And with so many people falling ill and having had COVID myself, I'm grateful for my health. And with already over 2.6 million lives lost, including friends and colleagues, I think this pandemic has made all of us rethink our priorities and remember how precious life is. Thanks.
Thank you very much, Dr. Kassim. I think we'll move on to our next speaker, please, just in the interest of time. Thank you, Dr. Amira Balharath, who's Director of Clinical Training and Administration at King Fahd Specialist Hospital in Riyadh, Saudi Arabia. Thank you.
Okay, I'm trying. Thank you so much. I'm trying to share my slides. I don't know. Can you see my slides?
Not yet, no.
I'm not sure if I don't know what's wrong, but if Pauline online, if she can help me to share the slide from her end.
Amira, do you want me to share them for you?
Yep. Please go ahead, please.
Thank you.
Thank you so much for this invitation. It's my pleasure to be here. I'm Amira, colorectal surgeon. I trained in Dublin, and I'm currently the Director of Clinical Training Administration in King Fahd Specialist Hospital in Dammam. I'm coming to the presentation. I'm coming to the COVID-19 from totally different angle than the two previous presentation. I'm talking about the training itself and how the surgical training affected. So in the first slide, as you know, can I move the slide myself or you can, or from your side? Okay. So the training in Saudi divided by province. So if you look into the yellow part, the Eastern Province, where I'm working and where the King Fahd Specialist Hospital is, we have total of 6 cities and total of 10 training centers. And the King Fahd Specialist Hospital is the leader, and all of these training centers under the umbrella of Saudi Commission for Healthcare Subspecialty. I'll talk about mainly if you move. Okay. Pauline, can I move the slide or you can move it? You keep just, okay. So I'm currently working in King Fahd Specialist Hospital, and if we have the organization structures, I'm explaining it in the next slide. We go from the CEO, executive directors, and then we have here our clinical training administration, including the allied health, nursing department, postgrad medical education, and scholarship. We have a total of 14 residency program. Move on. And we trained in 2020 around 372 trainees. On the other hand, we have also fellowship program, local fellowship program. We have total of 23, and we managed to train in 2020 39 trainees. Move on. So as I mentioned, we have 23 fellowship program and we managed to train 39. And it's worth mentioning in the next slide that we have a lot of collaboration with Bahrain. We have a lot of joint program between Bahrain and Saudi, where the trainee can travel between the two countries. We got residents, Bahraini residents and fellow trained in Saudi. Next slide, please. Our academic year is a slight different than Europe, I think, or Ireland. The resident, they usually have the interview March and April, and they start the year in October. They rotate every 6 months, and they have written exam and the clinical exam by July. For fellow, they do the interview in September. They start the year in January, and then they do the exam after completion of their training with around 2 or 3 years, and it's usually in March. The start of COVID-19, we have, if you move the slide, we have the first case, which is announced in Saudi, was on 2nd of March, 2020. And unfortunately, the first case was in Eastern Province. By May 27, 2020, we have total of 76,000 cases, and we have 411 deaths. The whole healthcare system, as what's happening, I think, in Dubai and in Bahrain, was rapidly reshaped and to cope with this emergency and to optimize the resource and minimize the spread of the infection. We shift from a patient center to community center approach in order to face this pandemic. The problem with the training starts from May 2020. One of the immediate change that we did for our training program that we stopped all in-person contact. So we stopped all the medical meeting, all conferences, and we replace it by webinar and Zooms and recorded lecture. Another very challenging problem at the start in May, that one of the major city was under quarantine, and there was one of the major training where the trainee rotate between the or like come in and out from this city. So we did an immediate action. We asked all the trainee who's living in the same city to have the training with the same center. And we noticed there was some element of anxiety. So we offer some of our trainee like 2 or 3 weeks of freezing. And some of them I actually applied for freezing 2 or 3 weeks until we have better understanding of the pandemic. The number of our trainee was significantly dropped in second quarter due to COVID-19 precaution. All our rotator resident and fellows under Saudi Council for for health subspecialty program were directed to remain in their current training centers and don't rotate. Our medical student training were stopped. We reduced the number of intern observer to the minimum, and all newcomer who joined the training program during the peak were asked to sign declaration form from the MOH, the Ministry of Health, regarding their exposure if they have any recent traveling. If you notice here in this graph, there was a significant, huge drop in our trainee number in the second quarter. We divide the year by quarters, like every 3 months is a quarter. So if you look to first quarter, the residents were 140 and dropped to 21. And if you see like 66, the observer were the medical students 66, and we have 0. Now we're recovering by fourth quarter, resident, fellow, intern, but still medical students do everything virtual. Down the time when the Saudis start the curfew from 23rd and until the 21st of June 2020, we asked the trainee to remain in the same city, and we minimized the traveling. So as you know, because in Eastern Province, as I mentioned, 6 cities, and some of them, they actually not in Eastern Province, they go to Riyadh, in the capital city in the center, or go to the Eastern Province, so to the west. So we minimize the traveling for any trainee as much as we can. Some of the programs were only in the special centers. So we offer training housing within the hospital housing for special program. If you go to the previous, and we give them an option to have a research rotation program. We understood there is significant need for our trainee to give a hand in isolation center, in ICU, and the screening, and we divide the trainee into a liner. So we put the first liner is our infectious disease trainee, family medicine, internal medicine, critical care, pulmonology fellow, emergency medicine as a front liner in case if there is need for them in ICU or in facing this pandemic in hospital. And we thought this is a good chance, and it will have a great impact for them and for their training in the future. There were, as I think in all over the world, there were a lot of hospital announcements regarding meeting, regarding mandate masking, regarding traveling, and regarding like even work and OR. We had a lot of on-site and online critical courses was given to all our trainees, BBE, hand hygiene, training course, ACLS, critical support courses for ICU and non-ICU, CDC training courses were offered for free for all the trainee, all in the Eastern Province. And we faced a lot of challenge during the year from the training perspective. The first challenge, and I think worries, were the exam, because it was around July. So we rearranged all the exams for our trainee to be done, the written exam to be done online, and we modified the OSCE exam to be an oral session. And we managed to do it in time, and it was the whole exams were run smoothly. The second challenge we face that we have to do the interviews. So we did all interviews during the pandemic using Zoom. For example, in resident, we have 274, and we managed to do all interview over 3 weeks, and around 114 per fellows, and we managed to do it at the same time, 3 weeks. It was a bit of challenge to have Zoom, to have faculty, but we ran it successfully, and we managed to accept resident and fellows on time for 2021. Another challenge also, because as I mentioned earlier, still Saudi closing the border. Only with permission we can travel. If there is permission, we can travel to Bahrain, or Bahrain can come to Saudi. And if you can see, there was significant number of our trainee coming, for our Bahraini trainee coming to Saudi, and vice versa. But I think we're starting to catch up in the fourth quarter. One of the huge challenge is the surgical exposure. as was recommended from American College of Surgeons, that to delay all the elective, non-essential medical and surgical procedure to minimize the spread of the disease and to save the supply. Our resident was affected by this. We divided the residents, or many programs, they took this the approach of having teams. So for example, the neurosurgery service or general surgery service, they have teams where the teams can work 1 week and off next week. And this is definitely affects the resident exposure, affects their training in general. In our center, mainly in King Fahd Specialist Hospital, due to the impact of pandemic, our operating room utilization dropped to 33% from March to June. This reduction was affecting the trainee involvement, not only because the reduced number, and on the other hand, most of the cases which was done, it's usually done by consultant because we need to do it in a very quick fashion and we need to minimize time in OR. We had a task force consistent of anesthesia, surgeon, nursing, hospital administration to come up with a recovery plan for our waiting list. And we put the planning was including 5 evening block until 10 p.m., 4 weekend block, and we add additional 36 hours to our operating time. If you see in this graph, like if you notice in March, April, May, June, we have significant impact. We start to catch up a little bit but thank God by September, we're using 96% of our utilization time was nearly back to better than even normal. And I think we learn in our OR and our nursing staff, our hospital admin, how to deal with this kind of pandemic and taking the precaution, not affecting the surgical list or the waiting list. Another point was we were facing a lot of, I'm not saying panic, but a lot of anxiety from our scholar all over the world. We have a total of 63 physicians internationally between North America, Europe, 11 allied and 1 nursing. 8 of them request extension because they thought their training was affected by COVID-19. 4, they didn't start on time because of flights. And the 12, they finished, but they couldn't come back to the country because of the flight restriction. And this was a lot of emails, a lot of Zoom meeting between us as a training administration and our scholar, just to facilitate their journey either back to the countries or outside the country. I think as anywhere else, the virtual training and simulation center has very major role. So surgical channel, Blackboard, live podcast, we use them to catch up with the training. A lot of daily virtual learning become the form between the tutor and the resident and fellow to minimize the gap. We try to designate time for each department and each trainee to get into like Zoom meeting or team to get their training as much as we can. At a point that we notice from the training administration that there were a lot of anxiety, not only because of the pandemic, because of the training, because of the exam, because of the interview. So we established training well-being clinic, virtual well-being clinic, led by well-trained psychologists and consultant psychiatrists. And this clinic was on 5 days a week, and they can book session 10 to 15 minutes, 15 to 20 minutes, and then they can have an appointment. And it was really significant. We saw really significant improvement in their well-being, not only for the trainee, even for the trainer themselves. We also encourage our fellow and residents to be involved in writing papers, and we help them to have like appointments in our library or having access from home. And we managed to get 75 clinical research projects and 8 health quality improvements only from King Fahd Specialist Hospital Center. By 17 September 2020, the vaccination came to Saudi, and we start with the targeted group as I think all over the world. We started with 65 and above medical staff and people with comorbidity, and was given to Saudi and then Saudi for free. We started with 3 major centers, and by February 2020, we have 405 vaccination centers all over the country. We have a drive-through service for vaccine, and we have home visits for elderly people, as I think what's happening in Dubai. Until today, we managed to vaccinate 1,065,000 Saudi and non-Saudi through this vaccination center, 405, and we have only Pfizer and the AstraZeneca vaccine. If you move on, Pauline, yeah. During the pandemic, me and my team, we were very worried about our resident and fellow, and we decided to study what's happening. So we managed to publish a paper about the impact of COVID-19 on residency and fellowship training program in Saudi, cross-sectional study. We recruit around 240, 60% female, around 73% were around 26, 30-year-old, 42% surgeon, a surgical trainee, and 38 medical trainee. 76, they said they were working in quarantine area. 46.7% were obligated to change the hospital due to pandemic. 43, they got enough training of the PPE. 71, they got virtual training to maintain their educations. Very interesting point that we notice anxiety and fear in our trainee. 45% were anxious, 37% feeling low and depressed, and 53 felt safe and protected. And if you can see here down the table, we have significant p-value for our trainee that they felt depressed, 0.047. Just because I'm a surgeon and we focused, I asked specifically about the surgical exposure. In the coming slide, when we ask our surgical trainee about their surgical exposure, out of 179, 130, which is equivalent to 73%, they felt they have their surgical training was affected. And this was a point and trigger to make us focus more on simulation, to make us think about how these trainees will catch up to be a mature surgeon in the future. So, point to overcome in 2021 and 2022, as I mentioned, the surgical trainee exposure and the trainee exposure in general. We need to make sure that our surgical trainee are ready to become a mature surgeon. Trainee fear about their plan, worries about what will happen for their future. Definitely, there is also program director concerns about the level of training and the level of the trainee. We have a lot of budget limitation for our scholars all over the world. And these, I think, challenges for us in Saudi here to overcome in this year and coming 2020. I think we learned as a training administration that smart learning is critical and the need for psychological supporting program for all trainees at all levels. We learned also that the trainee well-being clinic is a must, and we're planning to keep this clinic ongoing as soon as we have a training program. We're currently working now, not only in the hospital, but with the whole Ministry of Health to establish very well-written training policy and the procedure during any future pandemic, hopefully not, but just to have it written in paper so how we can face it, mainly from training perspective. I will conclude with this slide. There are obvious training impacts and work plan change across all over the countries because of this pandemic. The slowdown of residents and fellow learning curve is inevitable, so the smart learning is critical. Routine activities, journal club, department teaching will still continue in webinar, and we don't know, like, when we go back to normal. The high level of anxiety and depression were noticed, not only for trainee, but even for the trainer and hospital healthcare worker. And we definitely need we need psychological support program for all the trainee and the trainers. Thank you so much.
Thank you very much, Dr. Amira. I have to say that I'm struck by the resourcefulness of all of our contributors in each of their respective countries, and how they've managed to cope with the most challenging situation that we will likely face in our lifetimes. Before we get on to some questions, and I'm conscious of time, and perhaps our President will tell me to end shortly, but we have one question from Dr. Al-Azawi, who for Professor Manaf, and he wonders at the infection rate post-vaccine in Bahrain at 23%. Would you like to comment on that, Manaf?
Sure. No, actually, so what was trying to say, we have a total of 607 infected cases in the Kingdom of Bahrain, out of 170,000 that has been vaccinated, that has received the 2 doses of the vaccine, and they have completed the 2 weeks. And that would give you the 0.36%. What he was referring for the 23%, this is when we looked at the reduction of transmission of the virus. We looked at 2 groups, and we looked at those who had 23%, those were the non-vaccinated, in comparison to the vaccinated, which were 13.6%, so an overall reduction of 42%.
Okay, thank you. I have a question for Dr. Amira, who is a colorectal surgeon. Have you, and we've heard from Dr. Kazim about the restriction and reduction on breast cancer surgeries. Has this been your experience in colorectal surgery also?
Yeah, to be honest, we have the same, but I think for colon surgery, because there is a lot of emergencies, they come with obstruction, and they usually it's becoming, like, rather than elective, it's becoming more emergency surgery. So we noticed that from March into June, most of our colorectal cancer surgery was done because of emergencies, either perforation or obstruction.
Okay. So we'll take emphasis. Dr. Kazim, have you any further comment on that?
Yes, I was just going to ask Dr. Manaf about the labor camp and vaccines in Bahrain. I mean, the labor camps have been something that has been a bit of a worry, not just in Bahrain and the Emirates, Singapore, where they've had huge outbreaks. So now that that the vaccine is being rolled out, are you specifically targeting those areas where, like the labor camps for vaccine? Because in Dubai, it seems, people go for vaccine on a volunteer basis. So if that is the case, I'm not sure how you're getting the message through to the people that really need to be vaccinated.
All right, so we have done three different approaches. So beside the media awareness in their own languages, and we have targeted a group that has an influence on them in terms of educating about the importance of vaccination. So that's number one. And number two, actually, we have created this mobile vaccination unit where we have to travel to their labor camp, and we offer the vaccine. So we have offered, for example, the inactivated vaccine, but for those who needed the mRNA, so we had to bring them to our healthcare facility just for observation, as you're all aware of the messenger that's required to be under observation.
Okay, great. Good to know.
Professor Manaf, could I ask you you made a comment about not closing borders, but yet I think we're having conflicting results that, restriction of movement, border closures, closing airways and so forth, that they have actually had an effect on the incidence. Is that what you feel about that perspective?
I think the right message, Martin, closure of the border would be beneficial if you apply during the early phase of the pandemic, but definitely not during the middle of the ends of the pandemic. I think that's a key thing. And Border closure would be depending on the infectious nature. So, for example, Ebola, it makes sense, but for certain infectious pathogen, you cannot just generalize this rule of closing the border. If you look into the literature, to be honest, looking at the real world effectiveness of border closure, there is really none that tells you. Most of the benefit comes from modeling, and modeling will be influenced by assumptions.
So I guess my interpretation of what's happening is that, sorry Manaf, we lost you there. I thought you had finished, but I mean, you can't have anything in isolation. It has to be a composite of many different factors. But could I ask the panel, and feel free to answer each and every one of you, what do you think in retrospect that you would change now, having had the benefit of almost a year and a half of dealing with this virus? Maybe Dr. Kasim, do you want to take that? Anything in retrospect that you might?
Yes, I think actually we in the Emirates, I think we actually did a good job. I think we recognized the issue early. We shut down early. One of the things I didn't talk about was when we were giving patients. I mean, I worked right through, even through the complete shutdown. And with cancer patients, I mean, we hear stories coming out of the UK where patients have had their chemo program interrupted or postponed or whatever. We didn't do that here. The nice thing in the private sector is that most of the big hospitals are in multiple buildings. And so what the private hospitals did was try to keep one building completely COVID-free, and the oncology would run in that building. So we actually did most things. I think the only thing I would do differently would be not to have opened that that corridor up that we did before Christmas. I think we had a couple months of where everybody was coping. Life had gone back to normal. The clinics were running. We were, trying to catch up with cases, screening, surgery, and I think that was, for me, that was probably not wise. And I think perhaps people thought the vaccine was coming. But, obviously vaccines take time, and, even if you have a vaccine, you can still transmit the virus. So I think that's probably the only thing is I would have kept it a little bit more restrictive at that point.
Okay, I'd just like to ask Dr. Amir the same question before I turn over to Professor O'Connell.
Yeah, like here in Saudi, to be honest, we took regarding the border, we thought about closing, and we closed very early. We closed the border from March until today. Like now we traveling very, very limited, only for business or like studying or educations. I'm not quite sure, but my personal feeling, I think it helps a lot. In Saudi, we are a total of 36 million. So and we have a lot more than 11 international airports. And it was, I think in fairness, it will be very difficult to handle if we open the border. This is only for flights. We have a lot of overseas that they can travel in and out. So in fairness, I think it helps. The number now in Saudi is around 300 for the last 2 months. We have a bit of increasement in January, but now we're 300, not more than 300. Our mortality rate very low. We have total of 500 deaths in general. Our recovery 97%. So to be honest, I think it's learning experience for all of us, and I think next year or year after we'll have a better understanding of what is right or wrong.
Thank you, Dr. Amira. I'm just very conscious of I will turn over to Professor O'Connell, and thank you very earnestly and sincerely for a wonderful presentation and your participation. Thank you very much. Professor O'Connell.
Thank you, Martin. And can I really thank our three presenters? You went to an awful lot of trouble. And actually, it was very interesting to hear the three different presentations. I mean, we had a presentation on public health measures and how effective and important these are. In fact, they are crucial. and the extent to which the Kingdom of Bahrain went to ensure that these were put in place was extraordinary, truly extraordinary, and was, of course, recognized by the WHO. I was fascinated to hear the effect in Dubai, and not wanting to blame our English friends, but we had a likewise increase in January, because so many expat Irish came back for Christmas, bringing with them the new variant of the virus, which has now become dominant in Ireland. And we had a really big peak. And of course, in Saudi, one of the things you did was you closed the borders for the Hajj, which was really an extraordinary thing to do for people of the Muslim faith. I mean, it really was going to the core of what it means in your faith. And it just shows how important it was. And then I really enjoyed your discussion about the effect on training and the health and well-being of your trainees. I think this is very important, and it is a message that we will have to continue. I think that was something you brought out, that this is something we have learned and something we will have to continue. I hope that this time next year we will be having a very different conversation. I suspect that COVID will no longer be a pandemic, it will be endemic. And that actually one of the strange things that will come out of this, a positive, is that our infection control measures in our hospitals will be at a level that we would have never anticipated. And that maybe, and Amira, being a colorectal surgeon, will appreciate it just as I do as a colorectal surgeon. We will be seeing far fewer post-operative infections because of our attention to infection control measures. Can I thank all of our speakers, because you've stayed up late at night. I know it's 11:30 in Saudi. So I can only say how much we've enjoyed it and appreciate your participation, and look forward to keeping in contact with you. So Martin and colleagues, thank you very much indeed, and good night to all of you who have attended.
Good night.
Thank you so much. Thank you.
Good night.
Thank you very much. Thank you.